Hi. First of all, I'm really excited. This conference was a fantasy of mine for the last year since I came back from the States, and thank you all for making that fantasy come true. I'm here, I'm wearing two hats. One is my day job at the Technion, where I lead a lab, biomedical data science lab. And my other hat is, before I came back, I worked at Ansem AI in Palo Alto, and since I came back, I work with Ansem Israel, our hosts here, and I'll tell you today about a project that started in Palo Alto and we're continuing here in Israel. So you probably all know Andrew Ng, one of the leaders of the new era of deep learning, and he likes to say that AI is the new electricity. I'm sure that if you've been to a talk of his, you heard that. And we see that startups, there are hundreds of startups that are transforming healthcare with AI now. But I want to take a moment to talk about the oil. If AI is the new electricity, then to make electricity, we need oil, and the oil for AI is data. And when we talk about clinical data, we can talk about two types of clinical data. One is data that is coming from clinical trials. This is data that we prospectively collect, actively collect. We can collect a lot of information on each patient, make it very, very accurate. And the data is collected in a way that we can tease out the effect of the intervention from all the heterogeneity. On the other side, we have this real-world data, which comes from many different sources, very messy data. And it's very hard to extract, to tease out effects from all the heterogeneity. One problem with real-world data is, at least in the US, this data is in silos. You can go to a hospital and they will collect your data, and then you will go to your primary care physician and he will collect your data, and then you go to a lab and they will have the data, and you go to the pharmacy and they will have data, but none of those talk with each other. And that means that we can't really understand, have a clear longitudinal picture of what is going on with a patient. The only place where all this data funnels to is the payer, the health insurance, and that's where Ansem comes to play. So Ansem, as Udi already presented, is a health insurance company in the US that covers 1 in 8 Americans. That's over 40 million Americans directly and over 100 million indirectly. It works in 14 states and in half of the states in the US. And most importantly for us, Ansem worked really, really hard in the last 10 years to consolidate all its clinical data, to build a data warehouse that includes that takes the data from all the different sources and create a platform that we can all access it for internal use, to develop all sorts of risk prediction models for internal use, but also, interestingly, Ansem, as Udi already mentioned, for external use. So Ansem created this digital data sandbox with all of its data from the last 12 years, 45 million lives. The data is de-identified. And Ansem really wants to share that data with the world, with researchers and the industry. Yeah, you can see here some numbers. This is a very, very extensive data set with tens of millions of patients and laboratory data and pharmacy data. And we can really do great things with it. And as I said, we want Ansem to understand that it has data and it needs to work with the greatest minds to use it. One other problem that I want to talk about is with real-world data is what Ron already mentioned, this efficacy effectiveness gap. Those are systematic differences between rates of efficacy reported in clinical trials and effectiveness in routine clinical settings. We've seen many papers in the last 10 years that show this gap, where clinical trials show some results and the effectiveness is sometimes even the opposite. And if you try to think what are the reasons for that, we can split it to two reasons. One is, as I already said, the data in the real world data, it's really hard to separate, to tease out the effect of the treatment from all the heterogeneity. But on the other side, we can think of another reason why this happens is because real-world characteristics are very different from clinical trials. Again, Ron already mentioned that. As you see in the picture, the people in clinical trials have unique characteristics. They are very different from what we have in the real world. There are differences in adherence to the treatment. There are co-medication interactions. The guidelines, the physicians are not following the guidelines. There are access barriers to healthcare. There are many reasons why real world does not replicate clinical trial. But if you think about it, we don't really care about what happens in clinical trial. We want to know how that intervention will work out in the real world. So we'll just finish that and say that there's a lot of value for us to try to measure the effectiveness in real world and not just in clinical trials. So think of yourself, you're an oncologist and patients come into your clinic and you need to decide what treatment to give to that 56-year-old female with non-small cell lung carcinoma, stage 4. And you go to the ESMO clinical practice guidelines and you look what are the possible treatments, and you see one treatment or another treatment or another treatment, and you don't really have a good idea how to choose between them. None of those treatments were tested, compared in clinical trial, because the way clinical trials are designed, and there's no data usually to support which is the best treatment for that patient. So one of the things that I've been working on since I joined Anthem is creating this database from the last 5 years of 200,000 patients, 500,000 treatments. And this data set that comes from many different types of cancer has unique features that we can't usually find in other, I don't think you can find in any other cancer database. So it's not just the cancer type, the pathology, and the stage, which actually is tricky in many data sets. We also have information about the line of treatment, the first line, the second line of treatment, the performance status, is the patient in symptomatic or asymptomatic. Those are really important when we try to measure prognosis. And we also have information on biomarkers and demographic and metastatic sites and surgeries and radiation and things like that. And all this is coupled with outcomes, mortality or recurrence. Just to show you the breadth of this data, I looked at the number of patients treated with immunotherapies in that data set, and you can see here, for example, if this works, never mind. If you can, for example, melanoma patients, we see about 8,000 patients treated with immunotherapies. If you go to all the hospitals in Israel, you have about 200 patients a year that are treated with immunotherapy in melanoma. So in 5 years, that would be 1,000 patients from all the hospitals together. Good luck with getting all that data. And this data set is still at least 8-fold bigger. Okay, so let me give you one example of the things that we can do with this database. So metastatic pancreatic cancer, terrible disease. After diagnosis, you can see here the decision tree of how you make the decision, and eventually, at least in the US, for the metastatic patients, there are 2 possible treatments, FOLFIRINOX, which is a platinum chemotherapy, and gemcitabine nab-paclitaxel, so under the name Abraxane in the US. Abraxane is not in Sal so most patients in Israel receive FOLFIRINOX, but in the US it's about half receiving each. So as we said, when they did the clinical trial, FOLFIRINOX was tested against the state-of-the-art back then, 10, 15 years ago, which was gemcitabine, and also Abraxane was tested against gemcitabine, but there was never a clinical trial that directly compared those 2 treatments. And you can't, it's very hard to take 2 clinical trials, the results from them, and combine them because the patient, the selection of the patients is very different many times. So we are not the first one who thought about this problem because it's an important problem. Abraxane is still under patent. It's very expensive. FOLFIRINOX is much cheaper, but on the other side, FOLFIRINOX have much more toxicities. So it's a complicated decision which treatment to give to the patient. And as As I said, many have looked at real-world data to look at this comparison between FOLFIRINOX and Abraxane. You can see here the numbers, about 15 studies, dozens to hundreds of patients in each study. Many of them are missing, I think, key important features that we have in our data. And when we looked at our data to look for patients receiving FOLFIRINOX or Gemabraxane, we found about 2,500, which is about the sum of all those studies that I showed you in the last couple of years. And I'll show you, this analysis was done by Avital and Brill at ANSEM Israel. So naively, we can create this survival analysis comparing FOLFIRINOX and Gemabraxane, and you can see here that FOLFIRINOX is more effective than Gemabraxane by about 3.5 months. The cheaper drug, more effective. But this is a very, very naive comparison because of all the confounders. There are differences in age. FOLFIRINOX patients are younger. There are differences in the performance status. Because of the toxicities, FOLFIRINOX patients usually have better performance. There are socioeconomic differences. There are differences in the metastatic profiles. There are differences in the other comorbidities. We also see changes in practice. Now physicians are prescribing more FOLFIRINOX than Gemabraxane. And there could be many other confounders that we didn't think of. To show you an example of performance status, so you can see here how important it is to correct the performance status. You can see here the survival for patients in good condition, usually asymptomatic, performance status 0. They have a much better prognosis of patients in performance status 1, and much, much better prognosis than patients already in, that are almost half of the day are bound to bed. So now we have all those features, and we have our two groups, and we need to use all sorts of causal inference methodologies to adjust for those differences between the two arms of our comparison. And we used 4 different methods. Stratification is we match patients based on the values, and we run it again and again to all the different values, and then we combine it all together. We can use one-to-one matching, which is similar to one Ron talked about for the vaccination. For each patient, we find a twin patient on the other arm. We can use co-proportional hazard, which is what Malka talked about, which is, you can think about it as a regression with sensor data. And we can also use the inverse probability censoring weighting, which is also called propensity score matching, where we weight patients based on all their features. And you can see here, for example, on the match score and the one-to-one matching, we still see FOLFIRINOX more effective than Gemabraxane. When we stratify based on the performance status, you can see here that for each of the performance statuses, still FOLFIRINOX is more effective than Gemabraxane. And as a summary, you can see here all the different methods. After the adjustment, the hazard ratio is very similar in all of them at about 1.4. We see differences in, if in the beginning we saw 3.5 months difference, after the adjustment it goes down to about 2.5, but still very, very significant difference. So I hope I convinced you that FOLFIRINOX is more effective, but is it worthwhile? All those patients, sadly, are going to die in probably less than a year, and quality of life is very important. So we looked at some post-treatment effects. For example, hospitalizations. So we look at the first 2 weeks after the treatment. At least in theory, FOLFIRINOX is tolerated worse. It has more toxicities, but doctors are now better in prescribing treatment medication to prevent those toxicities. And what we're seeing is increased hospitalizations in the Gemabraxane group. And you can think of those as unmanageable toxicities, which are the ones we really want to avoid. We also see, when we look at cost, which is another measure to measure toxicities, and we can see in the next 2 weeks after that patients on Gemabraxane are more expensive, again, suggesting that there's more interventions and to prevent all the different toxicities. So this was one example, but as I showed you, this data set is very, very extensive. We want to share it with the world. We created this app that we call the Oncology Browser, which you can put in all the information about your patients and use different adjustment methods, and eventually you will get a Kaplan-Meier plot for all the different treatments. And we see this as a way that in the future doctors will be able to use this data to make the best decision treatment for the patient. So thank you very much, and I'll be happy to take questions.
Question.
Thanks, Dvir. Very beautiful work, very impressive. One thing, I'm not sure if it's even a question, but something worth noting. When you look at the survival curves, it was, I think, very reassuring to note that after you do the corrections for all the other features, you get two curves that actually start in the first month or so very much alike and only seem to diverge later on, unlike the two curves that you showed initially before you do the correction. And I think to me that when I look at that, it's the most reassuring thing, because like you wouldn't expect the drugs to do much in the first few weeks. And once you do the correction that actually shows a behavior like that, this is highly reassuring. And that, I think that appeared in some of the corrections, but not in others.
Yeah, great comment. Not a question. I'm going to tweet to Oded Rechavi that you asked a comment, another question. Yes, so as also Ron showed in the vaccination, they did the matching until they saw that there is no difference in the first 14 days. I think that's exactly what we are hoping to see here. We see that the curves diverge in the naive with 4 adjustment. The curves are starting to diverge very, very early, which makes no sense or suggests that it's not a result of the treatment. But if, as you mentioned, when we do the adjustment and we look at specific performance statuses adjusted to age and all the other confounders, we are seeing that at least in the first 2 months, there's almost no difference between the groups.
Okay, I think the rest of the question will be offline. Thanks, Dvir, again.